folks. This is Dr. Alice Lee. Welcome to September 2020's IQ episode. I hope you're all well, and I hope you have not gotten weary of wearing your PPE. That's so critical, okay? Make sure to protect yourself so that you can serve others. Well, I have a fabulous guest today. He doesn't really need an introduction, but I'm going to try. So, my guest was my attending in medical school 30 plus years ago. Oh, geez, that kind of ages me. He is the section chief of pediatric emergency services at the University Hospital of Syracuse, New York. He is the emeritus director of Central New York Poison Control Center. And he's a professor of emergency medicine and pediatrics in Upstate Medical University, my alma mater. So I am super, super privileged and excited and greatly honored to have Dr. Richie Cantor as my guest today. Welcome to iCubed, Dr. Cantor.
It's a pleasure to be here. It's nice to look at somebody's face without a mask. But it's great to be able to do this, and I'm really happy. And I can't say enough good things about this educational format because in EM, we're interactive, we're engaging, and we learn from our cases.
That's
this is exactly the right way to learn.
Yeah, I think that we're all storytellers. And so that is what I've tried to do with the iCubed is just tell stories, real stories, and work through them sort of in real life and with authenticity. All right, so I am going to show Dr. Cantor some video of kids that I have seen, 2 kids. So patient number 1. That eye, my friend.
Can you open your eyes for Grandma? Look at Grandma. Look at Grandma. You trying, baby? Yeah. Grandma's gonna buy you. Trying, baby. Where did she get started, Grandma? Huh?
Here's patient number 2, 2-year-old. That first one was 3-year-old.
Okay, grab it. Okay. You're okay. Come here. You're okay. Yeah, you're okay. You're okay. So how's he gonna feel?
What do you think, Dr. Cantor?
It's impressive. When I saw the first child, I was, putting on I was committing a cardinal sin in emergency medicine. I was starting to think, okay, this has to be some toxin. This has to be who knows what. I don't have a history. I don't have any data here. So the bottom line is if I was going to teach my residents and to deal with this and again, whenever you're faced with a situation where you're pretty much clueless, we all know the first steps. I mean, A, B, C's, and D's.
Yeah.
And I can see that both of these kids, I guess we can get pretty basic, are moving air. I did hear some really noisy upper airway breathing in the first kid.
There was, yes.
Yet the second kid, while at rest, sleeping, really had no respiratory work. I didn't see any nasal flaring. I just saw the face. No pursed lips or anything like that. So I'm going to assume the airway's okay. The breathing is the stethoscope, not oximetry. Hopefully they were moving air, but anybody who's crying is moving air.
Right. I learned that from you, Dr. Cantor. If they're crying, they're moving air.
Well, it's like, you have your first child, your first baby, and you freak out when they get a splinter, and your second one falls off a building, and your wife says, "Is she okay?" I said, "She's moving air." She's cool. But, and I'm going to assume the circulation's okay.
Yes.
And everybody who's not normal in emergency medicine, but certainly in peds, gets a chem strip or a dexter stick.
Good.
I mean, I'm just going to do it. I mean, I give whole talks on sugar will screw you up. And kids have no glycogen. Their illnesses consume it. They lose it with nutrients. Who knows why? And it's kind of foolish to wait, 40 minutes for a basic metabolic panel when in 30 seconds you can get a finger stick.
Oh, yeah.
I've had it happen. Mea culpa. I've done it. So you really want to know if the sugar is okay. If assuming the A, B, C, D for dexter stick is okay, I can take my time. Okay, I'll do the oral board format. What brings you here today?
All right. So the first child comes in and mom says she was playing in the pool, the empty pool outside, and then she suddenly screamed in pain and said, "Mommy, mommy." It was actually grandma. Grandma, something about I got bitten.
I got bitten?
Mm-hmm. Mommy, she's screaming in pain. She's screaming in pain with her.
Okay. Did you tell the mom what part of her got bitten, where it was?
Her foot. There's nothing on the foot. If you look at the foot, there's nothing on the foot.
Okay. And subsequent.
Arizona. Remember, this is Arizona.
Unfair fight. That's a whole part of the tox boards I had to study. Crazy people in the Southwest. I'm not going to bite on the bite. I'm not going to call it a bite yet. I'm assuming that the child had been well prior to that.
Mm-hmm. Yep.
And how old are they? They look 2 to 3.
Right. The girl was 3 years old, and the boy was 2.
Okay. So there's no past medical history that's contributory.
Not at all. But I think that is, you're absolutely right. We have to kind of get much more history than just looking at a child's physical examination. And so I think that's a great point to make.
And I'm going to ask a quick and dirty OSAT. What's the oxygen stat?
Perfect.
Good. One less thing to deal with.
Yeah.
All right. So you ostensibly you would go to a secondary survey at this point. And basically the first pitfall in this kind of situation, in any toddler or child situation, is not, again, oral boards format. It's not undressing the child completely.
Excellent.
You don't, I'm not looking for needle track marks here or stab wound on the back. I'm looking for envenomations. You never know where the bite is. I'm looking for bruising. You all know the incidence of, non-intentional,
right.
Rather intentional trauma. You really have to be careful about that. And especially in a setting where you may not be getting a reliable story from a perpetrative caregiver. So look at the skin. I'd also look at the skin for things like, is it hot or is it cold?
Right.
Yeah. And I guess at this point I'm allowed to ask vital signs.
Oh, absolutely. So vitals are really all within normal limits. There's nothing abnormal or suspicious on the secondary physical at all.
All right. Well, let me bring up a point. What I noticed in the first child was I was disturbed by the noisy breathing. And, we'll get to that. But there was a fair amount of secretions and going on. And it's a non-specific finding at this point. But if I go to toxidrome world, it matters to me whether you have a wet or dry mouth. When I see a lot of secretions in somebody who's been bitten or maybe had gotten into some product,
right,
I look for a toxidrome and, the wet and dry phenomena. And there's a golden rule in tox that if you are having mouth secretions, bowel sounds, and diaphoresis, you could not have taken an anticholinergic. And especially in the purity of a 2 and 3-year-old who's not a polypharmacy abuser, who got into an accidental single drug exposure. Whereas the adolescent world, all bets are off. It's just medicine cabinet shopping.
Yeah.
But let's play that game.
Yeah.
Somebody had secretions, pardon me, by definition, that's cholinergic. And one of the biggest and most dependable things about cholinergic people, if you remember, is the pneumonic sludge
Okay.
Salivation, lacrimation, urination, defecation, gastrointestinal upset.
Great.
But you're just a wet mess.
Yeah.
But what is also is the bradycardia that comes with it. And a pissed off, freaked out kid can't override a cholinergic bradycardia with a tachycardia.
That's a great pearl, actually. These children were not bradycardic. That's a great
And remember,
pearl.
you know this. I mean, you learn this in pals, apples, pick a fruit. That heart rate keeps kids alive. It's not their diastolic pressure. It's all heart rate. And anything that's their number one physiologic adaptive mechanism. So anyway, if this kid's not bradycardic in the face of stress, it'd be difficult to assume a cholinergic drug was at work, to be honest with you.
I agree.
But you got to think about it. So back to baseline. So the vitals are okay. All right. If I strip a kid naked, besides bites and trauma, I'm certainly looking for rashes. I mean, I'm allowed to ask what time of year this took place.
They were both in the spring, early summer.
Yeah, all right. Well,
in Arizona.
I got it. What I'm alluding to is in Syracuse, because we have these things called seasons.
Yeah.
You remember?
Touche.
You still have your winter coat. Anyway, the punchline here is that in the winter season, people go indoors, shut the windows, and carbon monoxide could be in play. So we have to pay attention to that. That would apply also to some unvented vehicles and whatnot, and cherry red skin, all that cyanotic stuff. It's not happening here, but you really want to look at the skin color. But I was struck by the cheeks being bright red in the child. Now, again, I'm not going to do an internal medicine rounds thing and
right.
causes of red cheeks, but I still have no idea what's wrong with this kid. Okay, but I'm going to earn it. I'm assuming the pharynx was clear without exudates or petechiae.
Right.
Was there an odor? Any odd odor?
No, kids do not have odors. No.
Now let's talk about the pupils. The pupils are a toxicologist's best friend. In the sense, again, in a single drug ingestion. Where there's any, you said they were reactive.
Yeah, they're equal.
Good
and their eyes, their pupils are hard to see, to look at carefully.
They're screaming, keeping their eyes shut. Okay, that's fine. That's real life. I saw the neck was supple. And I'm assuming there's no gumbas in the neck, no big nose.
Right.
All right. Is there crepitance in the neck?
No. Mm-mm.
And the air entry is equal bilaterally with no, and the heart sounds are rapid and loud.
Yes. Well, loud covered by the gurgling.
Yeah, no. I got it. And the belly has no masses.
Correct.
I assume it's be impossible to see if it was tender in that setting.
It's hard to tell, yeah, because they're writhing around.
The genital exam, the reason you do it is you want to be a complete clinician.
Right.
One of the things I thought about with the slap cheek appearance, I mean, again, you threw the word bite out there, and I mean, I write it down in my brain, but that's not the end of it. There are a couple of slap cheek events that you have to pay attention to. Everybody, knows about Fifth's disease.
Right.
And this is a big teaching point with me, especially febrile kids, is really step back from the kid and see if there is not just redness to the cheeks, but circumoral pallor. Comes with strep. And the way you figure that out in children of color is you ask the parent. And you ask them to look at the face. And in dark-complected children, it may be hard to see the erythema on the face, but you'll see a paleness around the mouth. That's almost always strep, but that's not going on here. But just
but that's a great program.
And you've heard me talk about this strep. When I was going through med school, I figured I would die from, some hypochondriacal disease that we all had. But we all had stuff that was going to kill us. And so I always thought it was going to be Ebola, Kuru, Tsutsugamushi fever. Well, I think it's gram-positives, quite frankly. And
that's going to get us all at the end.
My point being, they're bad mojos. These strep and staph bugs make toxins. And whether it's pharyngidity, impetigo, scarlet fever, toxic shock, erysipelas, the toxins are known for their dissecting of proteases and hyaluronadases. So I look at the groin, let me get to the point, for erythematous perineal rash, which would go along with strep, which happens quite frequently. Again, this is just a grab bag of things to look for while I'm doing a genital exam. The rectum is not going to help me much here. I'm assuming all four extremities move well without deformity.
Yeah, they're all symmetrical, writhing all over the place.
Okay, let's get to the brain. One good thing about crying is it's a mini cranial nerve exam. If you think about it, kid opens his eyes, you got a third nerve. The kid looks at you, moves all four directions. There's 4, 6. We're having a good day. The kid screams. It's symmetrical. That's 5 and part of 7. I don't care about 1 or 2.
Yes.
You get a gag response. You've got a little glossopharyngeal, a little phagal. It's not hard to do cranial nerves. What I'm alluding to, and I'd really like to know, is mental status of these kids. They were both non-distractible from the exam.
Right. They're normal mental status.
Okay, that's huge. That's huge.
Yeah. Oh, yeah.
Because if you're assuming, again, bite notwithstanding, you'd certainly have to consider an encephalopathic toxin. Yeah. And there's a lot of drugs that make you crazy.
Yep.
Mostly in kids, let's go through it, the most common toxidromes. The opiates will just knock you down.
Right.
You get wacko. So those are easy. Bradycardia, tight pupils, death to the smooth muscle. Cholinergics really don't affect your brain as much as your distal musculature at the nicotinic receptors. And you'll be hyperreflexic and you may seize. But if you're going to do that, you're going to be salivating, lacrimating, urinating, and all that. And anticholinergics are where the money lies here because they are very, very penetrant to the blood-brain barrier. And there is something called the central anticholinergic syndrome, where you might not get the pupils and the dry mouth and whatever, but your brain is fried and you're crazy. You're encephalopathic. Mm-hmm. That's why it used to be called loco weed or Jimson weed or different preps and whatnot. And there's 5 billion drugs that have anticholinergic properties and plants. So I'm just leaving that out there. But it sounds like these kids are alert and oriented times 3.
Yeah, no, that's a great teaching point about anticholinergic. These kids were, at least I know the girl for sure is very appropriate. The 2-year-old boy, again, he's just too young to really to talk.
Yeah, but if he hates you, likes the parent, you get my point. So I still don't have a clue what's going on here. I'll be honest.
Well, that's good to know. I have stumped the legendary, iconic Dr. Cantor.
I haven't stumped me yet. But the key thing is I know that whatever I'm going to look for is targeted at this point. I earned it.
It tickles me that you don't know what this is.
Oh, no, I kind of do know, but I want to ask you something.
Yeah.
I'm in denial about the bite. Because, wait, did the second kid have a bite?
Yes, they both had a bite. But actually, the proper term is envenomation. All right.
So let's go back to the bite part. Forget the toxin part of it. The first kid, especially with the secretions in the stridor, is this kid anaphylactic?
No.
You know what I'm saying. Does this kid merit an EpiPen and some steroids and the usual gamish? All right. So what bites are out there that don't affect the brain? Obviously, spiders are common. And not as much in Syracuse. It's too cold.
Remember, it's Arizona. What's a famous bite in Arizona?
Well, there's tarantulas. There's centipedes. There's scorpions. I'm just running this is why I don't live there. I'm terrified of bugs. My wife deals with that stuff.
All right, folks. Yeah, I hope you have some idea what's going on with these kids, because it is a very common toxidrome, if you will, in Arizona. But I think that we should at least talk a little bit about the differential diagnosis. I'm going to let Dr. Cantor kind of go quickly through these with some salient points. I'm
not going to claim geographic liability here, but tetanus, I've seen a bunch of cases in the unimmunized world. And in Syracuse, besides the vegan crowd, that's in Ithaca.
Yeah.
we see it in the Amish and the Mennonite communities. And with farm accidents and penetrant wounds, I've seen tetanus. The thing that's important to remember about tetanus is that cognition is normal. The trismus, the abdominal rigidity, the epistotonus is pronounced, especially the trismus, but they're awake and alert. Botulism, these kids are kind of old. And you got to remember with botulism, there's two ways to get it. You either eat the toxin that's preformed in the food, or you eat the bug who gets in you and makes the toxin. But that only happens to babies. If you and I ate Clostridia botulinum spores, we wouldn't get sick. Our acid pH in our gut would kill it. Babies would thrive. So he's not a baby. But I'd ask the question, but look at botulism. It's a hypotonicity disease. However, the stridor, remember, that's glossopharyngeal and vagal. You want to be careful. Neuroblastomas, they just don't show up like that. Neuroblastoma, the neurologic finding is often raccoon eyes and epistotonic behavior, myoclonic jerks. So you don't see that. Organophosphates, we talked about the speed world, meth, coke, PCP, and the like. They share a lot of common findings. Again, dilated pupils, right? Tachycardia, hypertension. But the deal breaker is sweating and salivating. If you sweat and salivate, you're no way you took an anticholinergic. Antihistamines in pediatrics, another pearl, equals anticholinergic.
Right.
H1 overdose equals anticholinergic. And strychnine, which I haven't seen very much, to be quite frank, but that's hypertonicity as well. The seizures are always at the bottom of anybody's list. And the foreign body is not a joke. The stridor on the first kid bothered me.
Yeah.
But I noticed though, and Alice, you were there. This kid was able to lie back on his and recline on his back. So I don't think it's a pronounced upper airway event. Kids who are air hungry from an upper airway thing assume the jaw thrust chin lift position.
Yep.
So we're back to the bite.
Now, as you guys all know, I boil everything down to 2 learning focuses for each episode because we have too much to talk about. But learning focus number 1.
Bark scorpion.
So both of these kids were scorpion envenomation presentations. I have seen hundreds, probably, very mild to very severe cases. So I looked up and up to date, and lo and behold, the author is Frank Lovecchio. He's a legendary tox guy over at the Maricopa Emergency Medicine Residency, from where I'm a graduate. Scorpion envenomations are graded, from mild to severe. Grade 1, 2, 3, and 4. And I'll tell you what, I was stung by a scorpion about 10 years ago while I was sleeping. So grade 1, it's simply restricted to local pain. Like people they're reaching down for something or reaching around something, get stung, or they step on it. So it's just local pain at the site of where they were stung. This paresthesia, for me, it was my shoulder. And so there's some local pain, paresthesia. The puncture is really too small. You can't see it really. When you look at the skin where the envenomation is, there's nothing really noticeable about it. And there's really no local inflammation. So there's no redness, there's no blistering, there's no nothing. Grade 2 would be a little bit more extensive, local pain and paresthesia plus remote symptoms. Children actually may present with unexplained agitation or crying. That's thought to be a grade 2 envenomation. Grade 3 is more serious. Grade 3 has cranial nerve dysfunction or somatic skeletal neuromuscular dysfunction with or without autonomic dysfunction. So cranial nerve dysfunction would be dysphagia, increased oral secretions, abnormal eye movements, and slurred speech or tongue fasciculations. I've seen these many, many times and very common in the victims of envenomation. And an important point is to know that with the increased oral secretions, it can cause airway issues with these, with children in particular, because they have such small airways. Grade 3, somatic neuromuscular dysfunction will be restlessness, shaking, jerking, fasciculations, alternating arching and bending, writhing movements, and you can see that with the kids that I showed. Now, grade 4 is the most severe. Grade 4 is defined as having both cranial nerve dysfunction and somatic neuromuscular dysfunction. But in real life, on close exam, victims of envenomations with skeletal muscular hyperactivity, they usually have cranial nerve dysfunction. And so, most of these threes actually are fours. Some severe cases have stridor, like the girl. So general management would be just the vast majority of my patients with envenomations I've treated this way. So you observe the patient in the emergency department for 4 hours to ensure there's no progression of their symptoms. And then before you discharge them, you must make sure that they are tolerating PO fluids and the pain is under control with oral meds. And then make sure to update their tetanus. What do you think, Dr. Cantor? Did you learn something there?
Learned that I'm not leaving Syracuse. I know where my enemies are. And I don't have to worry about these envenomations. My enemies are the admitting resident, the surgical consult.
That's hilarious.
The neurosurgeon and the radiologist.
Learning focus number 2, scorpion envenomation treatment. Anascorp. So I bet people outside of Arizona and Mexico know nothing about Anascorp. So I'm going to teach you guys all about this. Academic Life in Emergency Medicine is a terrific blog. And first of all, you have to decide who to treat with Anascorp, right? So you have to grade your patients. If it's a grade 1 envenomation, it's just simple, like Dr. Cantor said, ABC, support the airway, you provide pain control, you can apply ice to the site of the sting if it helps. If it doesn't help, don't bother. Grade 2, there's pain and paresthesia remote from the site of the sting, so you can just pretty much treat the same as the grade 1, okay? I started my practice, my emergency medicine practice back in 92 when I finished residency. And back then, there was anti-venom available, but we didn't use it very often because of the really high percentage of serum sickness. So most docs, ER doctors, when we saw a patient like this, we would just treat him with benzos and just observe them in the emergency department for hours and just treat them with pain meds, treat them in benzos, and then you just watch them for 6 hours or whatever until they got better, and then they were sent home. So that's how it was for the longest time.
Don't negate the benzos as a universal antidote for an unknown ingestion where there's tachycardia, hypertension, maybe disorientation. One of the magical things that benzos will do for you, let's say these kids had atypical seizures, temporal lobe epilepsy, something wacko, and you hit them with, midazolam, pick a benzo, and they got all better. You would have interrupted status.
Right.
I've had that happen to me with encephalopathic anticholinergic kids, and I thought it was just it, and they had other things. So benzos, in tox world, when you don't know what the hell to do, give them a benzo.
There's a soundbite I'm keeping.
You know this. You've done it.
Yeah. So then if we are seeing a grade 3 or 4, you would use the benzos to start with, and then
can't hurt.
It can't hurt. You're right. To start with, and then you would give the Anascorp for both 3 and 4. Okay. So let's just talk a bit about Anascorp. So Anascorp is a centroides scorpion immune Fab 2 fragment. It was approved by the FDA in 2011, and it's standard recommendation for grade 3 and grade 4 scorpion envenomations. Okay. Unlike the earlier version of the antitoxin, the Anascorp has a very low rate of serum sickness. I remember early on, I would have to warn the patients, the parents, that they need to be followed up in about 2 weeks, because especially if they have any joint pain. And then the package insert for Anascorp recommends 3 vials initially, with an additional 1 or 2 vials up to a maximum of 5 vials. Now, this is not a cheap drug. It's $3,000 to $4,000 per vial, okay? Huh. Yeah. But, should we follow the package insert? This is a very legit question, because when it first came out, there was a lot of media coverage, scorpion sting leaves Arizona woman with a huge bill. Henderson, Nevada, a Henderson woman slapped with big bill from scorpion sting, $18,000. And scorpion anti-venom sticker shock. Arizona story, Arizona ABC 15 story, with $32,000 bill. So there was an article that Academic Life in Emergency Medicine refers to. Its primary author is Dan Kwan, who is also a toxicologist at my alma mater, Maricopa Medical Center Emergency Medicine residency, along with Frank Lovecchio. And so the bottom line of this is the most important part. Their conclusion was that in this retrospective analysis, children in both single vial serial dosing group and 3 vial full dosing group achieved symptom resolution within 4 hours of initiating therapy with no additional complications or adverse clinical outcomes. So then the post on bark scorpion sting in the Academic Life in Emergency Medicine, this is basically their conclusion. So when you have this scorpion patient that's grade 3 or 4, consider starting with just 1 vial of Anascorp and observe for 30 to 60 minutes before administering any more. It may reduce the financial hardship of patients. So that is actually a legitimate real-life concern. I remember clearly that there was a big uproar in Arizona. Well, I just wanted to bring up quickly some of my experience with scorpion, Dr. Cantor. I had a infant that I intubated because of a scorpion envenomation.
Well, because the airway is so narrow and so small.
Yeah. This was 10, 15 years ago. Dad brought the baby in just terrified. Baby was drooling, stridorous, and it was a non-walking infant, maybe 10 months old. And she was really in a lot of distress retractions. So I wound up intubating her. And then I've had lots of very mild ones. But there was one that's a slightly side story, but it's interesting. Dr. Steve Curry, he's over here. Yeah, so again, early in my career, mom brings a baby in saying that she got the baby got stung by a scorpion. He was just restless, would not calm down. And I hold the baby down. And by then, I'd seen lots of scorpion envenomation. So I hold the baby down, and I look at the face and look at the eyes. There was no nystagmus. Not at all. The baby was looking at me. There was no abnormal movement of the eye. But the baby was very, very restless. And I'm like, I don't know. So I tried some Ativan. Didn't do a thing. So at the time, I had just, finished residency. It was still, I think Dr. Curry probably still remembered me. So I called him over in the tox center in Good Sam. And I said, hey, Dr. Curry, I don't know what's going on. And blah, 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 explain it. And he goes, why don't you try Haldol? If it's methamphetamines, the Haldol should work. I was like, wow. So I gave the kid Haldol, and he calmed completely down. Right. So I asked the mom, is there any way that he could have gotten just meth? And mom started crying. She goes, yeah, I think my mom uses meth. And we found out later on the mom had hidden meth under the crib
mattress. Yeah, common drug area.
But the point for me was that I thought there's no way this is a scorpion envenomation. Just isn't. I don't know what it is, but it isn't. The eyes are perfectly still. There's no abnormal movement of the eyes at all. And almost everybody that I've seen that was significant toxicities with all that neuromuscular activity have cranial nerve abnormalities. So that was just, to me, really impressed in my brain.
In the end, you think about, I don't want to make everybody stop thinking, but once you do the diligence of the primary, secondary event, you can take a minute and take your time. And you know what? Don't be afraid to send somebody else in the room to do another history, because mea culpa. You honed right in on it in Arizona. Nobody in Syracuse would think of a scorpion. Nobody. Not an excuse. It's just an explanation. So.
Okay, not an excuse, just an explanation. I get it. I say that a lot.
What are you going to do?
Well, Dr. Cantor, thank you so much for joining me today. This is great fun. I've always really enjoyed your lectures, and I really am proud that I'm from the same university medical center or medical school as you're at right now. Well, folks, I hope you learned something during this episode, because it sounds like I taught Dr. Cantor something, so that's wonderful for me. And
very stressful, very stressful.
Well, Dr. Cantor has influenced and taught legions of emergency medicine physicians that are practicing still today, and so it's a great honor for me to have time with him today. So, hey, I hope you guys are having a good summer, and please don't be weary of wearing your PPE and stay safe, okay? So we'll see you next month. Bye.
Bye. Thanks for having me, Alice. Take care.
Bye.